Now we move forward with our other topic of acute GI failure in ICU, navigating challenges. Chairpersons for the topic are Dr. Pankaj Parikh, he is a senior physician at Anand, Dr. N.S. Panchal, he is also a senior physician at Anand, Dr. Hiren Patel, he is a gastrophysician at Iris Hospital Anand, Dr. Mitesh Makwana, he is a nephrologist at the Shri Krishna Hospital. I would like to request Dr. Mitesh Makwana to introduce the speaker.
Hello, hello. I hope we will all enjoy the post-lunch session. Good afternoon, ladies and gentlemen. On behalf of Karamsad Intensive Care and Pulmonary Symposium, I am honored to welcome you all on this session of acute GI failure in ICU patient navigating challenges by Dr. Ganshyam Jagathkar. He is a DNB teacher, director and senior consultant at Medicover Hospital, Hyderabad. He has got numerous papers and prestigious papers and publication in various prestigious journals and conferences. He is the awardee of Dr. APJ Abdul Kalam Health and Excellence Award and ISCCM Presidential Citation Award. I am Dr. Mitesh, privileged to serve you as a chairperson today with my senior colleagues and friends. Our session aims in providing insights for managing this kind of complex patients in ICU. Without much delay, let's delve into the discussion. Over to you, Dr. Ganshyam.
Thank you, chairpersons, for the kind introduction. And at the outset, I would like to thank Dr. Sameer, Dr. Abhishek, and Team Karamsad for inviting me over here. This is my first time in Anand, and I have really enjoyed the hospitality and the scientific deliberations happening since morning. Acute GI failure in critically ill, immediately post lunch, probably appropriate topic at a inappropriate time. Nevertheless, there is something which is very, very important and often neglected in intensive care unit. And so when we look at gastrointestinal tract, most of us, we look at GI tract only from the perspective of digestion or absorption, or from the perspective only nutrition. But what we tend to forget is, apart from providing important nutritional functions, your gastrointestinal tract is very, very closely involved in various other functions like endocrine functions, offering adequate immune, capabilities to the body. And we have had a enormous discussion in the previous section where we highlighted the importance of the gut microbiome in the emergence of drug-resistant bacteria. And many a time, you would find that if your gut is not functional, it would invariably lead to other organ dysfunction. The concept that the gut may not be an imminent or innocent bystander, but sometimes the initiator or the motor of multi-organ dysfunction has been well established now. But unfortunately, despite being such a vast organ and despite having such an important influence on the outcome of patients who are admitted to the intensive care unit, if you see all the severity scoring systems, none of the severity scoring systems actually kind of include your gastrointestinal tract as one of the organ dysfunctions. You have SOFA scores where you have the lung, you have the kidney, you have the liver, you have the coagulation system, but the GI system is never or has not been included till date in any of the scoring systems. And the reason for this is when your SOFA score was actually introduced way back in 1994, almost about 30 years previously, they looked at involving the GI tract, but they realized that the GI tract was such a vast organ and defining parameters which could categorize at GI failure and then include that as a part of the multi-organ scoring system was very, very difficult. And that could be one reason why you will never find GI as one of the parameters in any of the scoring systems, and that's what makes it an invisible organ. Now we can easily look at what's happening with your renal functions, we can easily look at what's happening with your cardiac functions, we can easily look at what's happening with your liver functions, but when it comes to gastrointestinal system, we do not have well validated, objective and universal tools which can establish and categorize the intensity of GI failure. And even today, we rely heavily on the clinical parameters to tell whether your GI system is working or not. Now, there are certain radiological evidences, but it's not very commonly done. Similarly, unlike other organ systems where you have well-established biomarkers or perfusion markers, unfortunately, we do not have very well-validated biomarkers for, stratifying your gastrointestinal system. And when you look at gastrointestinal motility, now there are, GI motility is something which is very, very tightly and very, very closely regulated with the influence of your central nervous system, your autonomic nervous system, your enteral nervous system, which includes both your myenteric plexus and the submucosal plexus, and a lot of gastrointestinal peptide hormones. And in intensive care unit, either some part of the gastrointestinal system or the entire GI tract can have dysmotility, starting from the esophagus right down to the colon. Which part is involved is something that we cannot predict, but either as a whole, your entire GI system can have issues with motility, or parts of it can have motility. The fact that in general, in any critically ill patients, close to 50% of the patients have gastroparesis, and when you look at patients with increased intracranial pressures, be it a traumatic brain injury or be it a stroke, any condition where your intracranial pressures are elevated, close to 80% of the patients manifest with gastroparesis, suggests that in intensive care unit, your GI motility is significantly compromised, and that could be one of the reasons why your GI dysfunction or GI failure can manifest. What are the risk factors? If you look at all the risk factors, practically each and every critically ill patients can have some of these factors. It could be the underlying disease as well as some of the therapeutic interventions that we normally give to the ICU patients. For example, majority of our patients are on sedation and analgesia. So if you look at opioids or look at propofol, both these agents, which are very, very commonly used in intensive care, have a negative effect on your GI motility. Similarly, fluids is again something which is very, very commonly done intervention, and there is good amount of data to suggest that both hypervolemia as well as hypovolemia have a negative effect on your GI motility. Many of the patients who are admitted to the intensive care unit have a significant inflammatory response, and if you look at the effect of most of the inflammatory cytokines on the GI tract, they have a negative effect on the GI motility. Similarly, hypoxia, electrolyte disturbances, potassium and magnesium. We know that both these electrolytes are very, very closely associated with promoting your GI motility, and many patients where you have ileus, you tend to correct your potassium or the magnesium levels. Similarly, hyperglycemia, something which we don't give a lot of importance to, has a negative effect on GI motility. We know that patients with diabetics have issues with gastric motility, and a large number of these patients can have gastroparesis. And lastly, the role of gut microbial dysbiosis. Now again, that is something which we discussed in detail during the panel discussion on antimicrobial resistance. Critically ill patients, because of a lot of interventions, can have altered gut microbiota, and the protective commensal bacteria which are normally there are roughly about 45 trillion bacteria which are there in our GI tract. Now, any critically ill patient, with the interventions that we do, your gut microbia can be altered, and once your gut microbia can be altered, that has multiple effects. We know that the role that gut plays today in terms of the gut brain axis, in terms of the gut kidney axis, in terms of the gut liver axis. We know that if your gut microbiota are altered, there are multiple areas where it can influence, and one of the key parameters is your GI motility. So it's kind of a vicious cycle. You can have a condition where your GI motility is altered, which leads to altered gut microbiota, and this can actually precipitate a vicious cycle where the patient can go into refractory GI failure. So why do we actually need to worry about GI failure? I mean, do we really need to bother about what's happening with GI motility? Now, if you look at different data, it is very, very clearly established that if your patient has GI intolerance or GI failure, then one thing for sure, that this patient's nutritional delivery is going to be compromised. Your enteral feeding intolerance is going to be very high. Your nutritional delivery is going to be decreased. There is a good amount of data to suggest that if your GI failure happens, then certain molecular patterns or the disease patterns of the pathogens can migrate through the lymph into the systemic circulation and cause multi-organ dysfunction. So there is increased bacterial translocation because of the increased permeability that can happen in patients with GI failure. There is good amount of data to suggest that if your GI does not function and if the patients are on mechanical ventilation, then the duration of mechanical ventilation is increased. Similarly, there is robust data to suggest that if your GI does not function, then your ICU as well as your mortality, ICU length of stay as well as your mortality is going to be significantly high. Now, if you look at the various scoring systems, whatever irrespective of what scoring system you use, GI motility is a key component, and whenever you have a patient where your GI motility is compromised, you will usually find that these patients are associated with poor outcomes. And that is something that, for a long time, even our elders say that if your GI function is compromised, then you are bound to have some sort of health issues, and that is something which is evident very, very clearly in the critically ill population. Now, as I have said, there has been numerous attempts which have been made to kind of categorize or kind of give a scoring pattern to the gastrointestinal failure, starting from 1985 till as recently as 2019, 2021. People have looked at trying to grade gastrointestinal failure in some sort or the other. And if you look at most of the scoring systems, a lot of importance has been given to the motility part. How does your gastrointestinal system or your your GI system moves, either in terms of upper GI intolerance or lower GI intolerance? But despite numerous attempts being made, till date we do not have a very well validated and a robust scoring system which can include all the patients. 2012, there was a scoring system given by the European Society of Intensive Care in association with the Working Group on Abdominal Problems by Annika Reintam-Blazer, and they revised the terminology, and instead of calling it as GI failure, they introduced the term of which called as acute gastrointestinal injury. Just like you have acute kidney injury, they introduced the term acute gastrointestinal injury, and they gave 4 gradings. And subsequent to that, recently the same group has proposed a gastrointestinal dysfunction score. This was based upon a prospective study, close to about 540 patients. And again, if you look at the different components, a lot of emphasis is placed upon what is happening to your gastrointestinal motility, what is happening to your intra-abdominal pressures, and whether you have any kind of a gastrointestinal bleeding. Now, you have grades from 1 to 4. Grade 4 indicating life-threatening conditions where you need to have some sort of an advanced surgical intervention or some sort of an advanced intervention, and these patients generally include patients who have severe gastrointestinal bleeding with hemorrhagic shock, patients with mesenteric ischemia or abdominal compartment syndrome. Now, the other grades are based upon how severe your symptoms are and whether these symptoms can respond to your conventional medical interventions or not. Now, the biggest problem is how do you define gastrointestinal dysmotility? As I have said, if you look at all the scoring systems, they have kind of placed some sort of importance on how your GI tract moves. But till date, we do not have a clarity or a very well-defined definition to say how do you define an upper GI dysmotility or lower GI dysmotility. Again, if you look at different trials, people have used varying definitions of gastric aspirate volume or gastric residual volumes, which we commonly call as. People have used at, looked at anywhere between 150 ml to 500 ml to define gastric residual volumes. People have used at looking at the incidence of vomiting to define upper GI intolerance. People have looked at defining GI intolerance in terms of feeding inability to deliver or kind of inability to deliver anything more than 20 kilocalories per kg per day of your enteral nutrition after 72 hours of initiation. So we don't have a very clear, validated and well-defined system to identify patients with upper GI intolerance. Similarly, if you look at GI intolerance of the lower or the colon or the intestines, traditionally there has been some discrepancy of how do you define the patient having either ileus or constipation. Some people have used 3 days as a cutoff, some people have used 4 days as a cutoff to define somebody having constipation. So the problem with defining your gastrointestinal motility still continues. Do we have any tests? Okay, we don't have any clarity with respect to definition, but do we have any tests which can help us evaluate GI motility? Now, theoretically, if you go through literature, there are a whole list of tests which are available, but when it comes to practical application at the bedside in the intensive care unit, we have severe limitations as majority of these tests cannot be applied at the bedside. But if you look at the role of ultrasound, we know today that ultrasound has become an invaluable tool in the evaluation and the management of critically ill patients. There is definitely a role of ultrasound which is coming up in the evaluation of patients with GI motility as well as GI dysfunction. Now, this was the first protocol which was suggested, called as the GUTS protocol, where they looked at the role of ultrasound in looking at the gastric functions with respect to the gastrointestinal diameter, with respect to GI motility, with respect to mucosal thickness, with respect to peristalsis. Now, this was a little complicated because this protocol looked at the stomach part, the intestine in various quadrants, and gave a comprehensive score. Now, this is something which is a little difficult to kind of replicate or needs a very sharp learning curve. Subsequent to this, there was a modified score which looked only at the intestine, right? This is called as the acute gastrointestinal score, where they looked at only 3 components. One, they looked at what is the diameter of the intestine, they looked at what is happening to the thickness of the intestine, and they looked at whether intestinal peristalsis were there when you are putting the ultrasound probe and looking for the motility of the intestine. This is a much more simplified version, and the reason why I am telling you this is a simplified version is because we are doing this in our unit. One of my DRNB students is doing thesis on this subject. We have completed about 50 patients, and it's very simple. You keep the patient in supine position, you divide the abdomen into 4 quadrants. You can use a linear or a curvilinear probe. On the right side, just above the umbilicus and below the umbilicus, on the left side, above the umbilicus and below the umbilicus, you look for the intestinal diameter, you look for whether there is peristalsis present or not, and you look for what is happening to the characteristics of the intestinal wall. You take a mean of all these 4 readings and you give a score. And we have found that any patient where you have a modified GI ultrasound score of more than 3, there is, these patients tend to have poorer outcomes as compared to patients whose GI ultrasound score was less than 3. Hopefully, we will be doing this in more number of patients and come up with a publication. But this is something which can be done very, very easily. You just need a brief training of about a week or 2 to identify the intestine, to identify how you look at the diameter of the intestine, and to identify how you look at the intestinal wall. Something which can be easily done at the bedside, something which can be replicated multiple number of times, and something which can be kind of be done in any number of patients. The question is, once you have identified a patient with acute GI failure, how do we treat it? Now, for the upper GI intolerance, the routine is to give metoclopramide 10 milligrams IV 6 hourly, or erythromycin, though erythromycin is something which I don't use regularly because, again, the issue of that being an antibiotic and the what's going to be the impact of that on the emergence of resistance pattern. People have also looked at a combination of metoclopramide and erythromycin in conditions where your upper GI intolerance was not responding to a single agent. For lower GI, especially for constipation, you can try lactulose or the PEG, which is very commonly used in by the gastroenterologist. And in refractory cases, if your constipation does not respond to this, then you can look at using neostigmine infusion at 0.4 to 0.0 milligrams per hour for 24 hours. Trust me, there are many situations where I have used neostigmine, and many of the times it works very well. Just be wary about the side effects with neostigmine, especially if you have a patient who has an underlying coronary artery disease or a heart disease with blocks, then that could be a little tricky. can we or do we have any strategies where we can prevent the GI dysmotility? Now there are multiple trials which have looked at empirically giving lactulose or other laxatives. Again, the data is a little sketchy, but most of the trials where they have empirically given laxatives to ensure that the gut motility happens, most of the trials found that when you use preemptive or empirically laxatives or prokinetics, the ability or the nutritional delivery was much better, though there was not much of a difference in terms of outcomes. Now the greater question, how do we feed these patients who have gastrointestinal dysfunction? Now the common thought that comes to our mind is, should we give hypercaloric feeds, right? Especially if there is GI intolerance, is there any benefit of giving hypercaloric feeds, for example, feeds which are 1.5 to 2 kilocalories per ml? But again, if you look at the data, energy dense formula are not routinely advised. In fact, there is some amount of data which suggests that when you give energy dense formula, your gastroparesis can worsen. So don't, or conventional standard polymeric formulas are good enough. Similarly, do semi-elemental diets or peptide formulas offer any advantage? Again, as I said, as has been shown by data, they do not improve tolerability, but they could improve absorption. So in those conditions where you have GI failure with malabsorption, probably those are the subset of patients where you may consider giving peptide based formulas. Otherwise, a standard polymeric formula is good enough. Now when we look at gastrointestinal failure and managing gastrointestinal failure in the intensive care unit, please bear in mind that is not just about providing nutrition or calories. Your GI failure, yes, the most important function, or one of the key functions that we look at is what's going to happen with the nutritional delivery. But when you look at GI failure in the intensive care unit, it's not just only about how much nutrition you are delivering, because there are n number of other factors which have an impact on what's happening to a GI function. For example, resuscitation. As I've said, hypovolemia, hypervolemia are bad. Underlying disease severity is bad. So if you have a patient who is in shock, whose shock is not reversed, then your gastrointestinal motility is going to be compromised. So until unless your resuscitation is appropriate, your GI may not function well. Similarly, your sedation. Opioids have a negative effect on your GI motility. Propofol has been shown to have a significantly inhibitory effect on your GI motility or worsen your gastroparesis. So until unless there is an absolute need for sedation, try to look at what's happening with your sedation requirements. Electrolyte imbalances. I have said hypokalemia and hypomagnesemia have a negative effect on your GI motility. So make sure that you correct your electrolyte imbalances. Similarly, intra-abdominal hypertension or the abdominal compartment syndrome, many of us, we don't actually measure it. The general tendency is we just put a hand on the abdomen and kind of palpate and come to a conclusion of whether the intra-abdominal pressure is high or not. That is not the right way of doing it, because that can grossly underestimate the actual intra-abdominal pressures. So try to objectively measure your intra-abdominal hypertension, and if you have a condition where your intra-abdominal pressures are very high, try to look at how you can kind of decrease it. There is definitive role for prokinetics, laxatives and neostigmine in selected group of patients. And when it comes to nutrition, always have a very target and a protocol based approach for these patients, because you are not going to able to achieve your complete nutritional delivery or nutritional targets when you have a GI failure. So you need to go a little slow, start with slow volumes, have a definitive target in mind as to how much volume you want to deliver, how much calories you want to deliver, how much proteins you want to deliver. Relook at whether you have achieved your prescription, and if your prescription has not been achieved for any reason, then try to look at supplementing your enteral nutrition with parenteral nutrition, because again today it is a well established strategy. And in complicated scenarios, especially with severe GI hemorrhage leading to shock, or patients with significant intra-abdominal hypertension with a compartment or a peritonitis, you need to have a multidisciplinary approach, either colonoscopic decompression or a surgical intervention based upon the underlying disease. Now there are certain limitations. Now, for example, as I've said, a large focus as far as GI failure, whenever we talk about gastrointestinal failure, a significant amount of focus has always been placed upon the motility functions and the nutritional related functions. But we know that your gastrointestinal system is not just about providing nutrition and metabolic control. What about the enteroendocrine functions? What about the immune functions? We do not have any way by which we can measure this. So that is one of the major limitations in trying to know what is happening here with respect to your gastrointestinal tract. Similarly, do we have any biomarkers? For example, if you look at a cardiologic patient, it's very simple. A patient with troponin I elevation comes with an ECG elevation. We know that there's acute MI and a treatment is very well established. Similarly, there are n number of biomarkers. Last slide. There are n number of biomarkers for patients with acute kidney injury. A lot of biomarkers which have come up for patients with infection and sepsis. But when it comes to gastrointestinal failure, we do not have any such biomarkers. The only two biomarkers which have been studied or which have been extensively investigated is the citrulline levels and your intestinal fatty acid binding proteins. Your citrulline levels, they are basically a function of your enterocyte mass. So if your plasma citrulline levels are less, it indirectly indicates that the plasma enterocyte mass is decreased, which can happen in patients with gastrointestinal failure. Similarly, if there is epithelial damage to the intestinal epithelium, your intestinal fatty acid binding protein can be elevated in the plasma. But as I have said, studies have looked at these parameters, but we do not have any conclusive data. And lastly, we have spoken so much about the gut microbiome. How do we measure it? How do we have any specific interventions which can manipulate the GI tract the way we want to with respect to gut microbiome? We still do not have any specific answers for that. So there are a good number of limitations, but nevertheless, whatever be the limitations, the fundamental fact remains that if you have a patient and if there is some sort of gastrointestinal dysfunction, irrespective of the grade, if you have a patient with GI dysfunction, it is very, very likely that these patients are going to have poor outcomes. Thank you. I would also like to invite you all to the 9th edition of Hyderabad Intensive Care Symposium. Happy to take any questions.
As we draw the curtains over this session, I would like to add a questions from audience. Anyone want to ask a question? Then I will go for my questions. Actually, you rightly said that our patient of ICU, 50 to 70% of the patient have a gastroparesis. And you said that modified GI USG score is very much tricky for our residents and daily ICU doctors. So what you, in your practice, you suggest a clinical signs or symptoms or physical examination which are highly suggestive of that this patient is high likelihood of changes of gastroparesis.
See, if you look at, in my presentations, I have highlighted that still till today, we are relying heavily on clinical parameters to identify GI dysfunction. But unfortunately, your clinical signs and symptoms are neither specific nor sensitive, right?
Okay.
Now, for example, if you want to look at what's happening with the upper GI intolerance, we are looking in terms of either gastric residual volumes, right, or vomiting. Now, when it comes to gastric residual volumes, there is no specified, defined criteria to say that this patient has a upper GI intolerance. The reason being, how do you measure your gastric residual volumes become very important, right? What is the size of the Ryle's tube that you have placed? Where is the position of the Ryle's tube? Are you using an aspiration technique, or are you using just a gravity to measure your gastric residual volumes? There is no well-defined criteria to say that if you follow these parameters and measure your gastric residual volume, and if the gastric residual volume is more than this, then the patient has GI intolerance. But by and large, the general practice is if your gastric residual volumes are more than 500 ml, right, you would define these patients as intolerant and you would go slow on your feeding. Though again, parallelly, there is a very, very strong recommendation not to measure your gastric residual volumes on a routine basis, because it has been shown that if you keep measuring your gastric residual volumes, there is a tendency for decreased feeding. The second part, ultrasound is not difficult. Trust me, it is something, especially the younger generation who are very quick at adapting the newer technology. Ultrasound for gastrointestinal failure is something which can be done very, very easily. My DNB student is doing, I don't know how to do it, right? But it is very simple. You just have to go through a very formal training by a radiologist. What we did was, we asked one of our radiologists who trained this, trained her in identifying the intestines, how to measure the diameter, and she went through 1 week of practice doing that on every patient, and now she finds it very easy. So it is not a tough thing. Okay.
As a nephrologist, I always inclined to search out the causes of AKI, and you have suggested that intra-abdominal pressure more than 20 millimeter of mercury will change to the abdominal pressure and will develop abdominal compartment syndrome. For a residents to know that how it will cause AKI, so just 2 words probably.
I think one of the key is you're a nephrologist, you should be able to tell that answer better than me. But then again, see, we are looking at, whenever we are talking about organ failure in intensive care unit, right, the concept is changing about instead of one mean arterial pressure, we are looking at what's happening with the organ specific perfusion pressure, right. So each organ, if you break down to at a tissue level, each tissue has an arterial end and a venous end, right. So there is a pressure difference which determines what's happening to the perfusion of the tissues. Similarly, at the organ levels, you have what is called as an organ perfusion pressure. Okay. So in any condition where your intra-abdominal pressures are elevated, your renal pressures will go down automatically. So renal perfusion pressures go down, and that is one of the major reasons for your acute kidney injury.
And which method you use for intra-abdominal pressure measurement in your ICUs? Which method you use for
we use what everybody else use. We use the bladder, insertion of fluid, saline into the Foley's catheter, keep the bag at the iliac crest mid-axillary line, and you transduce that. That's something which is very well defined, well validated. You instill about 25 ml of saline into the Foley's catheter, and you kind of zero down at the iliac crest level, mid-axillary line, and just like you measure your CVP, you get a pressure on the your pressure monitor. So that's what we use.
I think we don't have much of queries now. Thank you, Dr. Ganshyam, for a very crisp and masterly talk. Actually, each intensivist should know what to do in ICU when you are dealing with the GI failure, because it's the most neglected, largest but still neglected organ, which we put a stethoscope on the chest, but we won't put a stethoscope over the abdomen. Even we don't bother to look at the abdomen, distension is there or not. So that is again, and the limitation, as you said, there is no objective scores which is available, validated score which is available internationally. But yes, ultrasound, I like that score which you have developed in your center and you are seeing. But again, the limitation is subjective, and in hypoproteinemia, you may get false dilatation of the bowels, thickening of the wall. So that again puts a limitation to that score. And one thing I would like to add is prucalopride is a drug. If you talk about the prokinetics, so that is again safer molecule 584 agonist, which we are using in our day-to-day practice when we deal with the paralytic ileus kind of patient. So it even increases the gastric motility as well as small bowel and colon also. And we are seeing good results. And compared to levosulpiride, which was an older molecule, which is quite safe for cardiac safety wise and all that.
So what was the new molecule you said?
Prucalopride. Prucalopride, yeah.
Okay.
So again, thanks. And with this, I think we'll conclude the session.
Thank you
if
very
anyone
much.
has any doubt and all.